Good afternoon. I'm Chris Gay, the CEO of Care Advisors. I'd like to welcome everyone to our virtual roundtable discussion. Today's event is co-sponsored by both Care Advisors and the Illinois Association for Medicaid Health Plans. We have a fantastic panel of health plan professionals joining us today. And Imhip's Judith Ruiz branch will provide you with some additional information to get us started. Take it away, Judith.
Thank you so much, Chris. As Chris just mentioned, my name is Judith Ruiz Branch, and I am the Director of External Affairs for the Illinois Association of Medicaid Health Plans. This afternoon's virtual roundtable will focus on the challenges to social care management and the breakthrough programs and other innovations that are underway to improve Medicaid managed care plans. At the end of the discussion, we will open the last 10 minutes or so to question and answers. So if you have a question at any time during the hour, please feel free to type it in the Q&A box on the right-hand side of your screen. And we will be reading those questions and getting to as many as we can. So with that, I will turn it over to our program moderator, Nona Tepper of Modern Healthcare Magazine, who has graciously graced us with her presence to moderate this today. Thank you, Nona.
Wow, what an introduction. Thank you, Judith. As Judith mentioned, I am Nona Tepper, and I cover health insurance for Modern Healthcare in Chicago. I'm pleased to be with you all today, and as our panel leads an important discussion on social care management. In addition to our hosts, Chris of Care Advisors and Judith from the Illinois Association of Medicaid Health Plans, our esteemed panel includes Harmony Harrington, Vice President of Government, Communications, and Community Relations at Blue Cross Blue Shield of Illinois, Imani Lewis, Vice President of Quality Improvement at Meridian Health Plans, and, providing us with a national perspective, Julie Falb-Heiber, a Principal at Health Management Associates. Let's start things off with Harmony at Blue Cross Blue Shield.
Much a pleasure to join all of you this afternoon. As the largest health insurer in Illinois, the health of our members is front and foremost for Blue Cross and Blue Shield of Illinois, as is the health and wellness of our communities. And diversity, equity, and inclusion, it just really permeates all areas of our company, from how we hire, to our support of business resource groups, to how we manage and interact with our members and our customers, and to how we help really create a positive impact on not only the physical health of the people and geographies we serve, but also the economic health of the people and geographies we serve. And our goal really is to provide a variety of products and services, access to care for people to have affordable, quality health insurance to meet their needs, regardless of their health status and regardless of their economic circumstances. And we have a long-standing history of helping to support that access to care and improving social determinants of health at hyper-local community levels, backed by data. We know that disparity can exist even between nearby zip codes. And if nothing else, the pandemic had clearly shown a really bright light on those health equity gaps. And tackling social determinant of health improvements really takes everyone. I'm so glad we're having this conversation today to lead efforts by the community and for the community. And we at Blue Cross support community health improvements through partnership and coalition building, and through a variety of engagement opportunities. You can go to the next slide, please. And can actually go to the next, where we talk about connecting with our communities. I want to give a few examples of partners that we work with and coalitions that we help to support to really improve SDOH in hyper-local geographies. We work with the Illinois Department of Healthcare and Family Services, state and local public health departments, healthcare providers, and nonprofit organizations to really help coordinate member care to improve health equity and social determinants of health, especially for our Medicaid members. And we do this through value-based care arrangements, through programs like our Hospital Health Equity Bonus Payment Program with providers, community supports, and enhanced care coordination. And certainly as part of that, we use data and software solutions focused on linking our members' social risk factors and matching them to social service providers, because we look at whole person healthcare and not just medical services they may receive through accessing healthcare coverage. We recently launched a new platform in August, and what we have seen through our Medicaid members is that users of our social determinant of health platform really fall in that age of females around 45 years old. And we see the highest number of referrals for SDOH supports in behavioral health and housing requests. Food insecurity falls inside that bucket as third, other social services, and then financial support for goods, services, and other healthcare needs. So some ways that we're tackling SDOH improvements, once we're able to identify them at a hyperlocal community level or a managed care Medicaid member level, is to reinvest some of the payments that we receive from the Illinois Department of Healthcare and Family Services. And for instance, as part of our focus on infant and maternal health this past year, we've provided grant funding to 6 community-based organizations working to improve maternal health outcomes on Chicago's South and West Sides. These programs focus on enhanced doula services, education, telemedicine to improve telehealth availability in early pregnancy and postpartum, help to support maternal morbidity prevention education, as well as pregnancy and early childhood at-home visiting programs to increase access to healthcare for young mothers. Some of these organizations that we partnered with include Catholic Charities, Chicago Volunteer Doulas, EverThrive Illinois, Melanated Midwives, Peaceful Birth Practices, and Women's Care Consulting. And so we also use other arms of our community engagement pillars. We use programming at our Blue Door neighborhood centers, health and wellness hubs located in Pullman, Morgan Park, and South Lawndale neighborhoods of Chicago to emphasize some of the investments and the work we're doing in infant and maternal health education and supports. So through our Blue Door neighborhood centers, we've done community baby showers, which are a really fun way to partner with nonprofits like March of Dimes and other local organizations to bring educational resources to expectant families, as well as resources. They've been a really popular way at a community level to engage in that type of health education. We're also working with Sweet Potato Patch, a meal delivery vendor, on a maternal health food distribution program, and nutritious meals will be provided to women and children throughout the course of a woman's pregnancy and into the first few months of postpartum. This program will be available in Chicago, Rockford, Kankakee, and East St. Louis. Again, just examples of ways that we build coalitions, we align investments and partnerships to help support those types of SDOH improvements at a hyperlocal neighborhood level. We have significant other ways in which we engage on SDOH, like food insecurity, as well as housing. And a similar model, we emulate our investments and our collaboration and our coalition building through each of our pillars of community engagement all across the state. And certainly during the pandemic, we have worked really hard with all those partners to increase COVID-19 vaccinations and boosters, health insurance enrollment information and navigation, all these things that have become front and foremost for Illinoisans as we tackle the pandemic together.
Thanks. Yeah, a lot of really impressive initiatives you've got going on. A question I have, because you are so focused on the community and their needs, I'm wondering, how do you identify the communities that you aim to impact?
Each of our programmatic investments are tied to metrics.
Very cool. And so you kind of use those metrics to help identify the communities with the greatest need, or the communities that, you know, offering these supports that you already have established could lead to better outcomes or lower costs. I'm wondering, there's a lot of need out there. How do you choose who gets what?
We certainly use the Social Vulnerability Index and other indices to identify where there are health equity gaps using our own data, or there are social determinant of health gaps.
Gotcha. Okay. Well, thank you for going through that, Harmony. And again, crazy impressive work you're doing. Imani, let's turn it over to you. Can you tell us a little bit about your organization?
Yes, and good afternoon, everybody. My name is Imani, and I am at Meridian. So, just starting out with a little bit of background about Meridian, we are the largest Medicaid managed care plan in Illinois. We have several different lines of business. We are focused on Medicaid. We're in all 102 counties in the state of Illinois. We also have the foster care or youth and care population. We have the dual eligible population, MMP or MMAI, and then we also have Medicare as well as Marketplace in Illinois. We are also part of Centene Corporation, which is the largest Medicaid managed care organization in the country. Um, we're in all 50 states, three international markets, and we have over 26 million managed care members in Centene. And so, what we're really focused on at Centene is we're focused on the individual. We really want to empower people to create healthy habits that last a lifetime. We're also focused on whole health. We want to make sure that we're delivering the full spectrum of care from physical health to emotional wellness. And then we're also really focused on having an active local involvement. So partnering with health associations, faith-based leaders, nonprofit organizations that are minority owned and women owned. So we're really tapping into the community to make sure that we meet our members where they are so that we're building a stronger and healthier community. You'll see a couple of points also listed here on the slide in terms of things that are a little bit of our secret sauce, focusing on accountability, where we take responsibility for the commitments that we make, and we want to deliver outcomes where we're showing that we are really invested in the health of our members. We focus as one team. We collaborate across all of our areas within our state. But again, like I told you, we're in all 50 states. So we do have a great opportunity where we're able to tap into our sister states and really gain some best practices and lessons learned, and even some new innovative ideas of things that we had not focused on or thought of. We're also focused on integrity. It's about doing the right thing. And so we want to be known and stand on that we're doing the right thing for our community first and foremost. And then again, just touching on that partnership piece where we not only collaborate with providers, government partners, community partners, but we're partnering with our members as well. So we have a very strong partnership with our membership where we're meeting with them on a consistent basis and able to get member feedback very regularly. And one of the things that we're very intentional about is reporting back to them how we took their feedback and implemented it into our practices. So the one thing that I really wanted to kind of focus on here is looking at health inequities. And so how we're focusing on creating more health equity throughout the state of Illinois. And so the way that we define health inequity is the systematic differences in health outcomes of different population groups. In order for us to achieve health equity, resources must be allocated based on the needs of those disproportionately impacted. And so you'll see the graphic here really kind of tells that story. So instead of really focusing on providing the same resources for everyone throughout the state of Illinois, we're actually looking at our membership based on different demographics to say, what are the needs of specific people? And giving them what they need as opposed to giving everybody the same resources. Because as you can see, if we gave the same resources to everybody, it doesn't necessarily create those healthy outcomes for everyone. So we have to make adjustments on the resources that we provide to ensure that our members have that equity in achieving health outcomes. And so one way that we really, or a few ways that we address health disproportionality at Meridian, is really stratifying our quality measures by specific demographics. So age, race, gender, geography. And we're focusing on those disproportionately impacted populations. And so I can tell you now, by looking at our demographics and zip codes specifically, we can say we're able to say these zip codes have higher rates of members going in for mammograms, for instance. And so we can show the differences between people who live in disproportionately impacted areas to show that their closure rates are much lower than other zip codes. We're able to do that for genders. We're able to do that for age, and so we're expanding how we're doing that. And then we're working with those communities to identify what those challenges are and what we need to do to improve in those areas. So specifically, we're customizing our initiatives to cater to those disproportionately impacted populations. We're working with key partners in those communities to be able to do that and provide the additional resources needed with those populations. And then we also have internal resources where we're able to apply social determinant of health data to improve those health outcomes. So a couple of examples. We are partnering with providers in specific disproportionately impacted areas, and we are working with them specifically to provide additional resources. So, providers, like I said, faith based leaders, different community organizations that we know have a presence in their community and they're already engaged and know how to really speak to the community and help get them the health care that they need. And the first question that we usually get from those partners are, well, how much does this cost us? And we're like, this is what we do. We're here to provide these resources, and there's no financial obligation of those community partners, and we step in and step up for the community.
Well, yeah, thank you for going through all that. I'm wondering, how do you measure success on these initiatives? Like, what does success look like for you? And any learnings you can share from some of these specific initiatives? I thought the one about mammograms was interesting, and I'm wondering if there was something you assumed at the start of the program that, as the program evolved, you realized, oh, if we refined this, we might have better outcomes.
Mhm. So I can use that one as a specific example to kind of answer your question. We partner with a provider on the south side of Chicago where we know that the zip code where that provider is located, as well as the surrounding zip codes, is predominantly African American. They have significantly higher rates of women who are not going in to get their breast cancer screenings. And we partner with that provider. We made the outreach phone calls ourselves, and we invited them to come in to meet with that provider to get their breast cancer screening. So obviously at that point we have, we know who needs to come in. We know how many appointment slots that provider has available. And actually we do this. This is a recurring event that we do with them every month. And we're able to show our success by how many women we're able to touch and get them in to actually get their mammogram. We do have anecdotal feedback. I've been to some of these events as well myself, and I've had women tell me, if you did not call me, I would not have come today. I've had a woman tell me that she had not been to the doctor since she had her kid, which her child was over 30 years old. So it was that one day where I got that feedback was amazing, because while, you can only get 20 to 30 members in to get that mammogram that day, to get that feedback and to hear that if it wasn't for us, they would not have come in that day, really shows that people touch matters. Um, we typically show up and provide food. We have food distribution at the events, so they leave with incentives or some sort of resource that population wants or is in need of. We've had a provider tell us that 30% of the women who came in that day needed follow up. based off of their mammogram. So it was an early diagnosis for them potentially having breast cancer. So we've definitely had some great outcomes come from these meetings or from these events. I think when we started out, we thought we would only be getting women in who would have probably gotten their mammogram anyway that year. But based on the feedback that we've gotten from the members, we're actually touching people who would not have actually gotten their mammogram if it was not for the event.
That is so inspiring. Thanks for going through all that. I'm wondering, did you have an aha moment, like when you realized, wow, if we started targeting the social determinants of health, maybe we could reach more underserved members? Amani, let's start with you, but Harmony, I'd love to hear from you on this afterwards.
Oh, absolutely. I think for me, my part of my passion is definitely engaging people who are not aware of the rights of having healthcare and knowing what resources are available to them, and so really helping get that message out to them, helping give them a voice in the healthcare arena, and letting them know that they do have the rights to healthcare. And so for me, that being able to really get the data so that I can raise my hand and say, here's what we know that there's a need, and we can definitely drive additional resources there. But I think it's the stories that are the aha moments for us, where I can actually speak to the experiences and the hardships that our members are facing, and that we were able to help someone out.
Thanks for that. Harmony, let's turn to you. Did you have a personal aha moment? And also, when it comes to Blue Cross Blue Shield of Illinois, I'm wondering, did your organization have an aha moment, or what kind of sparked this investment in the social determinants of health?
Thanks so much for that question. From a Blue Cross and Blue Shield of Illinois perspective, supporting SDOH improvements has really always been a fabric of who we are in the state of Illinois. From our employees to our community investments to our customer service centers all across the state. We've always had a really robust community engagement arm. We have an incredible team. I just get to be the messenger of folks working diligently and passionately at a community level. I'll give you one example that happened that was an aha moment for me, or perhaps a confirmation at a significant level over the past year. We embarked in a coalition to increase immunizations of the COVID-19 vaccine, mainly aimed at the senior population, and then we focused as well on our Medicaid members as well. And we worked in partnership with the governor and the Illinois Department of Public Health and the Chicago Department of Public Health. And we took two different tracks. We did direct to member outreach, offering transportation, helping to set up appointments through the state's appointment calendaring system that were for vaccinations that were geographically located close to those individuals. And those were phone calls and texts to members. And then we had our community engagement team out doing what they do through our Blue Door Neighborhood Center vaccine clinics that we did with Access Community Health, and our Care Van program, 3 vans that crisscross the state working with providers, all providing immunization education around the COVID-19 vaccine, helping to assuage any hesitancy issues, and then actually being able to deliver and administer the vaccines. And what we saw by way of results is phone calls direct to member, not as much uptake or really getting vaccines in arms. But when we leaned into our community engagement work with community influencers, nonprofit partners, our Care Van, our Blue Door Neighborhood Center, all really in someone's locale, right in the community, we saw incredible uptake in administering the COVID-19 vaccine. So that for me was proof in the pudding that hyper-local community engagement really can improve health outcomes.
Thanks for going through that. I found your commentary about how you reached out to members with multiple methods. Fascinating, because I always wonder, if somebody calls me, I may not pick up. If somebody texts me, I may not, click the link that's there. But with a van going into your community and engaging the community members, I think that's a really innovative approach. And I think that kind of brings us to our next speaker. At this time, we will turn to Judith, who will speak to Medicaid innovations, including changes to policy and care coordination.
Thank you, Nona. So in preparing for this webinar, there were so many different angles and avenues to cover, and probably the other panelists feel the same way. And I'm just so grateful to Care Advisors for highlighting this important topic and allowing Imhip to partner with you guys to do it. Today, I'm going to focus on two specific areas, which is policy and community outreach. But as I said, there is just so much to cover and discuss, but we only have an hour. So we had to choose two areas just to kind of hone in on. But I know that this is only the beginning of just a really important conversation that needs to continue to happen. That was highlighted by the pandemic, right? Something great did come out of, such an awful time for our country and for this world. But hopefully we are taking the lessons learned and the tools that we were able to cultivate to help us move forward and improve health outcomes for, the residents of Illinois, but also residents nationwide. So who is Imhip? So we're a member organization for the Medicaid managed care health plans. And as such, we work with Illinois state government, legislatures, advocacy groups, trade associations, and Medicaid patients to invest and provide high-quality healthcare focused on cost-effective, individualized care that helps the residents of Illinois live longer and healthier lives. The next slide shows you all of the plans that encompasses the Medicaid program. So the Medicaid program serves 3 million people in Illinois under these following plans. Harmony and Imani went through just a little bit, but we just wanted to include that just to show all of the plans that the Medicaid program encompasses. The next slide, we're going to focus on maternal health policy specifically, and why that's important is because every 1 in 2 births in Illinois are supported by the Medicaid program, and that's a huge demographic, right? So as such, social care management is so critical in addressing the systemic barriers that Medicaid members face in engaging with the healthcare system. So Imhip today wanted to highlight some of the notable strides that we've made as a state to ensure we're not only working to improve maternal health for all mothers in the state of Illinois, but that we are also acknowledging and addressing the various factors and policies that have been put in place that led us to these undesirable outcomes in the first place. Based on a 2018 IDPH report recommendation, Imhip worked with legislatures to extend Medicaid eligibility for pregnant individuals for up to 1 year after delivery to ensure that coverage is not a barrier for new families to access health care. Continuous Medicaid coverage will allow health plans to engage with Medicaid members more often and work to eliminate healthcare disparities. Medicaid coverage of doula care can result in a higher quality of healthcare for low-income pregnant women because doula services provide culturally appropriate and patient-centered care, and they can help to reduce the impacts of racism on pregnant women of color. Doula support is also a proven strategy to improve health outcomes for mothers and babies, reduce disparities, engage and increase the satisfaction of those receiving care, and improve the overall value of care. According to a 2011 study, the positive effects of doula care have been found to be greater for women who were socially disadvantaged, low income, unmarried, giving birth in a hospital without a companion, or had experienced language or cultural barriers. The medical literature demonstrates that racial and ethnic minorities and women are subject to less accurate diagnoses, curtailed treatment options, less pain management, and worse clinical outcomes than their counterparts. And although there is still so much work to be done to address systemic healthcare barriers, Imhip was very, very proud to be a part of the Illinois Legislative Black Caucus initiative in the spring to require implicit bias training for all medical professionals, because access to culturally competent medical professionals who listen to the needs of their patients is so critical in reducing these disparities. The second area that we wanted to highlight is on the next slide, and it's community engagement. So as state officials work to flatten the curve of the pandemic, Imhip and other member plans worked with HFS to find solutions. Our efforts resulted in many accomplishments, which some of them you've already heard from two of our health plans that are part of the Medicaid program. But these really help to mitigate the impact of the COVID-19 pandemic for Medicaid members. These community engagement activities taught us many lessons that, like I said, we look forward to building upon moving forward and not just highlighting right now. So recent CMS flexibilities and the state's use of quality withhold funds have actually allowed health plans to address these social determinants of health for the Medicaid population and to tackle disparities that have been exacerbated, as I said, by a global pandemic. In a recent 2016 rule, federal CMS clarified that health plans could include certain non-clinical services toward their capitation rate and the medical loss ratio as covered services. So this allowed plans to confront the social factors that affect the health of Medicaid patients, which is so important. Due to these flexibilities, health plans have been able to support the most vulnerable Medicaid members, as you have heard from Harmony and Imani earlier, with programs and offerings such as home delivered meals, partnering with local laundry services to provide free laundry days, offering transportation, and so much more during the pandemic. Health plan efforts to tackle the social determinants of health have also helped to move the needle on HEDIS measures. So, for example, access to transportation can greatly improve a Medicaid member's ability to attend preventative care visits and screenings. Inspecting a Medicaid member's home for mold can help with asthma management metrics. And extending secure housing to members could be critical in reducing healthcare utilization related to mental health or substance use disorders. HFS also released quality withhold funds that would have normally been used for the Pay for Performance program to the health plans during the pandemic to meet community needs. Health plans invested the funding into boosting behavioral health provider rates, improving telehealth capabilities, supporting Medicaid members with food and housing support, and enhancing COVID-19 vaccination efforts. And finally, just to wrap up, Imhip also, along with partnering on policy work and initiatives, and partnering directly with our health plans, as a trade association, we represent the entire Medicaid healthcare industry in Illinois. And so as such, we strive to offer all of our stakeholders with an abundance of resources that ultimately help to support the program and its members. Some of those include a resource center that we have online, that we've developed to include things like the comprehensive billing manual, MCO mandated training materials, prior authorization links, key contacts and escalation documents, and Imhip, our universal roster template. We also have other resources like our Sam Says podcast, which is focused on Medicaid managed care, and it reaches service providers, healthcare leaders, policymakers, community advocates, vendors, and health plans, and highlights and educates the community on important topics and partnerships and campaigns to continue supporting the needs of our community and members. We also offer regular webinars similar to this, and we'd like to partner with our community advocates and partners like Care Advisors. And so we're pretty proud about offering those consistently throughout the year to healthcare leaders, lawmakers, policymakers, our vendors, trusted partners, community advocates, and providers. And the topics cover a vast array of topics within the healthcare system. And they can be found on our website, imhip.net. And lastly, we also try to offer consistent content when it comes to newsletters and ways to stay up to date on the latest news and insights and policy, and just try to keep all of our stakeholders aware and connected when it comes to the Illinois Medicaid program. And so we send out quarterly newsletters, monthly insights, and all of those can be found on our website at imhip.net. So I will wrap it up with that, and just thank you so much for this time and this opportunity to present.
Thank you, Judith, and thank you for everything you do to keep the community informed and connected. Now let's circle back to Chris, who will provide us an update on Care Advisors' Urgent Needs Project.
Great. Thank you so much, Nona. Really appreciate the introduction. Just a quick introduction on Care Advisors broadly. So as a company, we focus on social care management, where we provide a comprehensive software platform integrated with live expert assistance, where we contract with health plans, hospitals, and community-based organizations to help them develop a comprehensive ecosystem to address the unmet social needs for their vulnerable populations. As part of that initiative, we founded the Urgent Needs Project, which is a series of community roundtables that we have throughout the country that include participation from elected officials. It includes feedback from frontline stakeholders, clinicians, social workers throughout the country to identify the root cause for constricted access to social services through various stakeholders and the challenges to collaborations that can address some of these barriers. A real focus of the Urgent Needs Project is, one, identifying those root causes for constricted access to social services, and then establish collaborations that leverage cross-sector relationships that include partnerships with providers, payers, and community-based organizations to address those barriers. Next slide, please. So when we look at the problem for social care management as a national issue, I'm going to throw some stats at you here in the middle of lunch. So we see it as a $200 billion broad problem. And when you think about that from a payer perspective, that's avoidable healthcare costs directly attributable to unmet social needs. The largest cause of that is housing, followed by avoidable healthcare costs related to food insecurity. And that includes an impact also from access to resources, including the impact for transportation and access to healthcare services broadly. When you translate that to a per member per year rate, that's almost $1,100 for every Medicaid member that you have in the country. So definitely a significant problem that you can look at both the macro and the micro impacts on. Next slide, please. When we talk with health plans on their social care management strategies, I think one of the biggest problems that we hear from them is around engagement for social care management and how it takes, there's really no silver bullet that solves the problem for them. If we look at one statistic, which is the closed loop referral rate, or more specifically, when a member has a social need that's identified and they're referred to a local community resource to address that need, the closed loop referral rate that we've seen through data that we've gotten through health plans and community-based partners is 7%. So you have 100 members that you have the identified social need, and 7 of those members actually get successfully referred to a resource to address that need. Now, that's taken from national data through referral relationships that we've seen throughout the country. If you look at the Centers for Medicare and Medicaid Services data for their Accountable Health Communities network, where it's mandated to track closed loop referral rates that they're funding these accountable health community networks on, they actually had a 2% closed loop referral rate, so much lower. So that is a significant problem for broad social care management. But let's drill down deeper to unpack some of the root causes here. Next slide, please. A couple of core issues that we've seen thematically in our discussions with health plans. One has been really the data challenges in both missing some timely clinical information and timely human services data on the members to accurately keep in contact and keep track of the status of social care management. We also see significant challenges on funding for social determinants of health. We've seen some flexibility during the pandemic that Judith highlighted, but largely a lot of these programs are funded through administrative dollars at the Medicaid plan level, either through pilot programs or grant making, and finding sustainability is a big challenge in partnering with community-based organizations. And a lot of this work is very manual. I thought Imani laid out a great impact for their breast screening program and all the work that went into the outreach and the engagement to bring in prospective members. And there's a significant cost related to that. And then you have the issues with some impossible situations where you're making referrals to resources that are overtaxed or that don't exist yet in the community when you talk about the systemic constraints around housing and food security that many underserved communities face. Next slide, please. One of CareAdvisor's contributions in terms of innovation in the space that we've been working on over the last year is our equity information exchange, which helps address some of the biggest data issues that we see around interoperability and helping to break down some of the proprietary data silos that you see amongst social determinants of health referral tools. That might be an Aunt Bertha's, a NowPow, or Unite Us. I think everyone that we see for healthcare organizations in the community has chosen to back a different horse. And when you're talking about these vulnerable communities, these proprietary data silos can be a barrier in and of themselves. So working to break down those walls by offering interoperability amongst these systems, and then combining that rich social services data with real-time clinical information through our partnerships with electronic health record vendors, really across the spectrum, from those that specialize in serving safety net organizations like Meditech and Centricity to the largest systems, including Epic and Cerner, but providing a comprehensive clinical repository that combines the human services data and then integrates that right into the workflows for providers, payers, and community-based partners. So the innovations around our equity information exchange have had a significant impact on helping to alleviate some of the challenges that you see with closed loop referral rates, which is a big issue. Next slide. I want to share some data with you that we've gathered from the Chicagoland area around constricted access to social services and what some of the insights that we see. So we included in the survey 76 social workers that were on the front lines for both community-based organizations and providers and care managers at health plans to get a sense that through their lens, what are some of the challenges that they see are having the biggest impact, both historically and in the midst of the pandemic, and as we're starting to get to some level of normalcy. The survey included social workers with a deep level of experience and diversity of experiences around clinical areas for healthcare support. Next slide. So when we look at the top social needs around the Chicagoland area, we really saw as a historical impact prior to COVID, housing security, government benefits, transportation, access to primary care and specialty resources, and access to affordable support were the leading top 5 causes or top 5 gaps that you saw in social care management. So some really significant issues. What I think is really interesting is when you layer in the impact of the pandemic, so next slide, and see a shifting of those needs where housing insecurity is still the number one challenge, but right behind that, you really saw an impact on economic instability and the challenges that everyone went through in the pandemic and what that meant day to day for your healthcare. If you can't stabilize your overall economics, the challenges in dealing with healthcare issues become that much more exacerbated. You also saw a significant increase in food insecurity, and those were in combination with the impact on economic instability. Both of those areas were directly impacted as you saw a shutdown of the broader economy. Next slide, please. So overall, some of the big insights that we identified as causes of constricted access to social services, one of the biggest areas in terms of the barriers on accessing social services were the administrative challenges. I don't think this is surprising to all the people that we have here this afternoon, whether it's dealing with government benefits, program management, or dealing with the collaboration between a health plan and provider and a community-based organization. The administrative issues and the overall cost are some of the most significant problems that you can face. And we also saw, I think, repeated in the same data that we've seen historically is a lack of follow-up. More than 75% of the social workers that we had discussions with had identified the data gaps and the challenges around follow-up were one of the most significant issues that they faced. So that concludes our notes here related to Care Advisors' interesting innovations on managing data and some of the interesting insights that we've seen from frontline workers dealing with social care management in the Illinois area.
Thanks for that, Chris, and thanks for your work connecting health equity data across systems. I think there's an old phrase, if you're not counted, no one can actually figure out what you need. So it sounds like you're helping to solve that problem. Julie is with us now to offer a national perspective on social care management innovations. Julie, can you speak to how partnerships with CBOs can impact care for members?
Absolutely. So the partnerships really help with access, gaining access to the communities. I think there's everyone is well-intentioned, but making those connections can be really difficult. And then CBOs can also supply the actual services of some of those needs that Chris was mentioning. But to jump into a few of the key points overall in terms of CBOs, they have that trusted vital services and access, as I was mentioning. They also, in developing partnerships between CBOs and health providers are really important too in terms of health equity, making sure, again, those health providers are often not able to get into the community. And so having those relationships with CBOs that have that element is very helpful. And then also working with the healthcare payers, either for social care management that Chris was discussing, or for other services to address social determinants of health helps as well. Moving on to the next slide. CBOs also can help with the biggest challenges facing the medical systems today. So if that's trying to get behavior change, that's extremely difficult on the very difficult end of the spectrum. CBOs have that trust that they've developed with the community that they're able to bring forward. CBOs do care management work. They clearly are involved in social determinants of health. And then also can offer patient-centered, culturally competent care. And as I was talking about that access earlier on, outreach to difficult to engage populations through their trust and involvement in the community. So CBOs are great partners. They're so critical to the community, but they also need support. They're diverse, and on Giving Tuesday, I think many of them are probably out there on your social media accounts. CBOs are diverse in size and type. Some are quite large, multi-service type providers. Those that are offering clinical services, and then there's some that are more grassroots, faith-based, and other cultural types of organizations that our earlier speakers were talking about in terms of their partnerships. CBOs can have multiple different funding streams supporting their service, and they often receive kind of service-only contracts and grants, so it's really difficult for them to build up their administrative capacity and infrastructure. It's a different kind of element than we have in the healthcare space. And so they have not often been funded with for their coordination with other providers or systems. And so this is a new element for some CBOs. And they themselves are vulnerable as a result of their funding streams. Some of their funding is protected, as I mentioned, for limited service only and very narrow. If that funding stream goes away, that can be really difficult for the organization overall. So looking at CBOs, a study done in 2018, 1 in 8 were technically insolvent. Nearly half lack the liquidity to meet immediate obligations. Nearly half reported a negative 3-year operating margin. And 30% of human services CBOs have no margin for error. They have very little cash reserves, less than 1 month of operating expenses. So these folks are so important to our healthcare system, but yet have some financial limitations to be able to do this work. And so partnering with clinics and other healthcare payers is really critical. Next slide. Just want to give a little discussion about HMA, the organization that I'm with. We're a healthcare consulting company, national organization with over 20 locations, but we're virtual, of course, as consulting firms are. Our background is we really focus on public programs, started with state Medicaid policy and local efforts around the uninsured, added in that healthcare delivery system, and also started working with insurers. We have a very strong Medicare practice as well, looking in now brought it into the social drivers of health. And like I mentioned, our main role is focusing around public programs. Moving on to the next slide. So looking at social services integration, what makes it work? What we've seen nationally is delivery system reform has to be rooted in health equity. That's a key element for its success. And successful reform requires engagement and expertise from these CBOs that we've been talking about that represent and are able to understand and reach these underserved communities and high needs population. So bridging that gap between the healthcare organizations and community-based organization requires some thinking on both sides, right? CBOs have to build that capacity, that administrative infrastructure, and CBO collaboratives can offer some of those vital supports to individual CBOs participating entities into the broader system. Also, partnering with insurers and providers are also ways that CBOs can build that capacity. And both the providers and health insurers can start thinking about working with entities that are not in their traditional stream. Moving on to the next slide. So looking in terms of required functions to work with CBO engagements with delivery system and insurers is having that connectivity to Medicaid billable providers accountable to those populations served. Having business planning to talk about rate setting, payer contracts, and management. How does that all work? Looking at identification and referrals of the population to be served. Having HIPAA compliant data collection, making sure that those systems are capable in order to be able to enter into these partnerships. Understanding billing, claims, and revenue cycle management is a key element as well for that infrastructure. Service planning and promotion is also key, something that CBOs are a little more comfortable with than some of the other areas. If there needs to be training or certification for those interventions, making sure those are in place, and tracking credentialing if that's also a requirement. Quality improvement obviously is really important, as well as measuring those outcomes. And so those are all elements that are required functions for engagement. Moving on. So CBO strategies can work in a number of different ways. It can be a network hub kind of method, multi-sector or single sector coalitions, and focused constituency models. In the interest of time, I'm going to jump on to the next slide, where we talk about some of the common features of these collaboratives. But I think we're going to skip on then to the next slide here. Just wanted to talk about some examples that are happening here in Illinois. Some of the other ones here are from some New York research, but the Illinois Transformation Grants are an element where have had as part of its key element an inclusion of entities that provide social determinants of health that are partnering along with traditional health providers such as hospitals. So awards have been made for the first round, but formal implementations yet to occur to evaluate those outcomes. But really encourage those on the phone to keep looking to see what these transformation grants will do in terms of outcomes. So strategies for health plan and system leaders as they engage. Listen and learn from your community experts. Be patient. It takes time to build these networks, and the most representative networks are the most successful, but that takes time. You want to tend to that relationship and trust building. Of course, this is avoid what didn't work before, and then be ready to roll with needed changes. Moving on to the next slide then. I think we want to get to some Q&A.
Wonderful. Well, thank you for that. And, thank you to all of our panelists, to care advisors and the Illinois Association of Medicaid Health Plans for co-sponsoring today's discussion, and to our participants for taking the time to join us today. I know we had some time, or we ran out of time to answer a few questions. So please get in touch with our sponsors by using the email addresses you see on the screen, and I'm sure they'll be happy to answer what they can and refer you for help for what they can't. All attendees will receive access to a recording of this session before the end of this week. Thank you again for your time.